Yeah, I think we can start. I will let you everyone present yourself, a quick presentation to let the attendees know where you are based, since how long you practice, since how long you use the QuickSleeper, and what you were using before the QuickSleeper in anesthesia delivery system. So Richard, you can start if you want.
Sure. My name is Dr. Richard Anderson. I'm a general practitioner in Pleasant Grove, Utah. I started using the QuickSleeper in November of this year. It's been a wonderful device to be able to, it's been a total game changer for my practice. Before this, I had tried the Intraosseous stab-a-dent system with not a lot of success. So I mainly do traditional anesthesia and struggle with it at times, for sure.
Thank you, Richard. Probably you can continue if you want.
Hi, my name is Dr. Prabdeep Sandhu, and I'm a general practitioner currently in Diboll, Texas. That's East Texas for you guys who don't know this part of Texas. I've been fortunate enough that I hopped onto this journey, was introduced by Dr. Andrew, who taught us this wonderful device. After it launched in September, I got started using it, and I think it's been 8 months now. And each day, I'm so happy that I have this device in my practice. I'm treating kids, I'm teaching adults, everybody's loving it. But I still have my syringe in my practice, my old syringe. That was the traditional syringe I used before. I'm excited to be here. Thank you.
Thank you.
Hi, Dr. Ramin Tabib with my wife, Dr. Elisa Mello.
Thank you so much. Ramin and Elisa, you can present.
Dr. Ramin Tabib, my wife, Dr. Elisa Mello. We practice in New York City. And we are the babies in the intraosseous anesthesia. I guess little over a month we've been using it. We haven't been using like a manual delivery of anesthesia in probably 20 years. We were the early adopters of the wand system. And so we really, it was an easy I wouldn't say easy transit, but it was a nice transition because we knew how to hold it, and we had to use a foot pedal in order to deliver the anesthesia. So the transition wasn't that challenging. And I did use stab-a-dent, like Richard, with not the greatest success. It was, it wasn't the most pleasant delivery of anesthesia. So although it worked quick, if it did work, it just wasn't predictable because you have to be very, good at detecting where to place it and where to drill through the bone. And that's really what it was. But this has been really there is a learning curve, I have to say, but it's been a good journey for both of us. I don't know if Dr. Mello want to add anything to it too.
It's been a nice addition to the office, and we're really picking up on it quickly, and it's really quite effective and really excited about it.
I was like the cowboy when it came in, so I wanted to use it right away. Elisa's a little bit cautious, she needs to analyze everything and read everything 200 times.
That's the variety of human beings, isn't it? It's great. It's great.
I just jumped in, and I remember I got Dr. Prynne on to deliver anesthesia on FaceTime with my assistant. So that was quite an adventure, and it was like, wow, worked. And
trust me, it was a big adventure for me too, because I couldn't get my hands on it. So frustrating. on
yeah,
FaceTime.
I could see the beads of sweat in your face.
You're so too right. but I think, Justine, it's not, there's no issues with, you said, you started that by saying I'm the baby of the, or we're the baby of the group. There's no issues there at all. We all started, you know, it's a journey, and you're just at the beginning of that journey, and it's brilliant to have you here. It's superb.
Yeah, no, I think we're very excited about it, and patients love it, and so far it's been rave reviews.
Good. So, Justine, are you happy for us to continue then?
Yeah, perfect. So Andrew, you can present yourself, and then we'll let you introduce Intraosseous anesthesia with QuickSleeper, and let you do your presentation.
Thank you, Justine, very much, and thank you all for coming on tonight. It's and thank you for everyone who's come to watch this webinar. We're all, as I've just said to Dr. Tabib, we're all in different stages of our development with this. It just so happens that I've got more grey hair, which means that I have been using it longer. It's simple as that. It's purely time. It's nothing to do with any stress levels, as I'm about to show you. My name is Dr. Andrew Prynne. I am a general dental practitioner in the south coast of the UK, and I have been at that office for 35 years. And since 2014, when I was first introduced to the concept of intraosseous anesthesia, my whole life has changed, and that is why I charge around the world talking about it, because it has made such an impact on my practice and my patients, as hopefully I will show you. We're going to try and keep the presentation part of this as short as possible, because I know that a lot of you will have questions, and we will aim today to answer those questions live for you. So let's start with the premise. We can't do what we do without anesthesia. Anesthesia allows us to form a relationship with our patients, and it enables us to do what we do. Now, Dr. Tabib started back in the 19th century, and he would have been in an office very much like this. Dental equipment has evolved massively over a period of time. Anesthesia was in its infancy at this time, but over the years, we have found that there has been development on so many levels with lasers, electronic devices, computers, scanners, facial reconstructions. It's the evolution of dental equipment has been massive. But in anesthesia, the little syringe we'd have used in the 19th century, we're still using today. And now I am in the position I am in, I find that quite extraordinary that that has not evolved until now. What's wrong with traditional techniques? Well, you might say nothing. It works. Our patients accept it, accept the treatment. We are comfortable with what we do with our little syringe. But I'd like to just make sure that you're aware that there is a dark side to the traditional techniques. And we're all aware of it, but we put it to the back of our mind. Let's look at some of these things. Time. Time is one of our most valuable assets in the dental office. And we spend a lot of time waiting for anesthesias to work. Now, Dental High Tech Americas will be able to provide you with this, and you can populate it with your own figures. But it is quite extraordinary that in this very conservative example, where we work 4 working days a week, 48 weeks a year, 10 anesthesias a day, if you total up the number of minutes that you wait for anesthetic to work, you'll get a weekly figure. Add into that your office, the cost of running your office, and that can suddenly become a huge figure when you extrapolate that to a full year. So time is a big issue. Control of patient movement, it's just something I came to realize that when I was holding the syringe, I would say about 1.5 miles away from the patient, there is very little fine control. We're all very skilled and we do great anesthesias, but this is something which we can get rid of. Collateral numbness. It's not just children who chew their lips after anesthesias. I've had adults doing it as well, and it's quite debilitating. Loss of motor function. Now, this is reality. This is what we do to our patients. Do our patients mind? No, they actually find it quite funny, but it is hugely debilitating to our patients. And when I say they find it funny, this goes across the board. Now, I don't know if any of you remember the great British actor Dudley Moore, who starred in the film 10, but after he'd had dental treatment in the film, this was actually portrayed in the film after bilateral mandibular blocks were given, and it was funny at the time, and we just accept it as part of society. So loss of motor function is a big debilitation for our patients. Appointment management is another issue. Unless we really don't like our patients, we're not going to give bilateral mandibular blocks, because the patient literally won't know where their face has gone. So we have to split those bilateral treatments up into 2 separate appointments, which involves getting patients out, in again, rebooking. It is a big cost to our offices. Now, the big one is probably the failed anesthesias. Johan Apps has done a lot of work showing clearly that inferior alveolar nerve blocks fail, not because the dentist is incompetent or is putting the anesthesia in the wrong place. They fail for very good anatomical reasons. Accessory canals with nutrient canals, bringing with them fibers from other nerves that exist in the head, will innervate teeth inconsistently. And so a block, however good it is, you get through the old restoration, you touch dentine and the patient jumps. And you think, what on earth happened? These are costly because they cost you not only in time for re-injecting the patient, but also patient trust and patient loyalty. It's a big issue. This causes a lot of stress both to us as doctors, but that is knocked down through the office. When a doctor is running late, you've got the hygienist who's waiting for them. They get stressed. Your nurse or your assistant who is with you is getting stressed because you're now running late, which means the receptionist has to deal with the patients out in the reception area. So it is a big stress issue. So going back to our premise that anesthesia lies at the heart of what we do, there are now new techniques and proven technology involving electronic delivery of anesthesia and intraosseous anesthesia, which can solve all of these problems. So we'll introduce you tonight as a panel, we'll introduce you to the QuickSleeper 5. I have been quoted at saying basically that, as my colleagues here have said already this evening, I personally cannot think of a new technology that I have introduced into my office that has made such a huge impact on my patient care, my own stress levels, and on the business. So what is QuickSleeper? QuickSleeper is an electronic dental anesthetic delivery device that enables a dentist to provide an immediate, painless, deeply profound and predictable anesthesia with no need for a second injection, no palatal injections or lingual injections, no numbness of the patient's face, and no loss of motor function. Hence, all of the solving of those dark side of traditional techniques. Now, we can divide the advantages of the modern technology into 2 features. First is electronic delivery of anesthetic, which I always used to think was associated with perhaps a bit of a lazy doctor who couldn't be bothered to press with their thumb. I was very, very wrong. When I started using this, I realized that in this animation with this manual infiltration example, when, however slowly I think I was pushing with my thumb, the anesthetic spreads and diffuses out before the vasoconstrictor has had a chance to shut down those vessels and keep the anesthetic there. So you get 2 things. You get a more diffuse area of anesthesia, and you get a much bigger area of collateral numbness. Compare that with the electronic delivery. Remember, this is infiltration. Very, very slow initial delivery, just drop by drop pretty much, will mean that the vasoconstrictors have a chance to shut down those vessels. All subsequent delivery of that cartridge remains where you put it, which means you get a much more concentrated effect of the anesthesia and a vastly reduced area of collateral numbness. And this was real, and I found it out by chance when I started using QuickSleeper. in 2014. Then we have the concept of intraosseous anesthesia. And for anyone who has not experienced this, this explains the whole thing. We're looking at what we're trying to anesthetize. And I'd like to put it to you that the apex of the tooth is the last common denominator. It's the last point at which nerves from whatever source, be they the main trunk of the inferior alveolar nerve, or be they from the accessory fibers coming in from other nerves, doesn't matter. If you can put anesthesia in or anesthetic solution in that region, then you will have full, predictable, and immediate anesthesia of the tooth. An animation showing the process. It's a 3-stage process using a very special needle. It's brought up at a very shallow angle to the base of the papilla. And that very slow delivery is made, which creates a residual blanching. When that residual blanching has been achieved, the periosteum immediately beneath it is anesthetized, which means you can now reorientate the same needle, make positive contact with the bone, painless, and then the needle rotates intermittently and gently and allows you to drop that needle straight through the cortical plate and into the cancellous bone. Once at the appropriate depth, then the anesthetic can be delivered, and that will fill up this box or chamber that is the dental alveolar structure. And once you fill that chamber, everything within that, all the nerves within there, are immediately anesthetized, including the tissues on the other side of the tooth. Now you say, why don't I therefore need another injection? Why has that caused or created an anesthesia on the lingual tissue? Well, that can be shown in this animation. Take this as a section through a cortical plate with the periosteum in pink on the external surface. With a traditional infiltration, we are delivering a bolus of anesthetic external to the cortical plate in the soft tissues. What happens is that that solution will diffuse through the bone, through the cortical plate, through the Haversian system and the Volkmann canals, and it will enter the cancellous bone. But it takes time, and in the meantime, you've got a face full of anesthetic. Take that now as an intraosseous delivery. We cut out the middleman. We deliver anesthetic directly into the cancellous bone. You still get a diffusion out through the cortical plate in 360 degrees around that site, which means that the periosteum all the way around that bone will be instantly anesthetized, and with it, all of the attached gingival tissues. So you do not need your second injection. The reality of this is that when you have delivered your anesthetic, you remove the needle, you can pick up a pair of forceps and that tooth can come straight out. There is no delay and no need for a second injection. Subtle difference between maxilla and mandible, and it's all to do with the blood supply. In the maxilla, there is a unidirectional, multidirectional blood supply, which means that at any given site that you deliver the anesthetic, you will get a symmetrical number of teeth, mesially and distally, none. In the mandible, there is a subtle difference with the blood supply in that there is a unilateral blood supply from distal to mesial. The effect of that is to just gently push or massage the anesthetic mesially, which means that you'll get one tooth distal to the site of entry and several teeth mesial, depending on the volume that you've delivered. That can be up to 8 teeth in the mandibular symphyseal region, 8 teeth with one injection. Planning the anesthetic is a combination of radiographic and clinical examination. So on a radiograph, you can quite clearly see where there is bone. And the rule is that where there is bone on any radiograph, there is definitely bone there. A radiograph will also, with the little red spots, if you look closely at the upper incisal and the upper left canine region, there are areas which perhaps you wouldn't choose to deliver an anesthetic into the bone. And that may be in this case because the roots are very close together. It could be due to pathology. Does it matter? Absolutely not. This is a continuous chamber or box. All you need to do is to deliver the anesthetic somewhere as close as possible into a good, healthy volume of bone, and you will achieve anesthesia of those areas. Radiographs alone can be a little bit of a problem because Here, for example, between the two lower mandibular molars, you may look at that radiograph and think, well, you can't get in there, there's no space. But it's not actually the case in reality, because this is the panorama of the same person. And you can see that there is plenty of room there. It's purely the angulation of the radiograph or relative to the beam, the X-ray beam. So in these situations, it's a combination really of clinical examination in addition to the radiographic examination. Here, for example, in a crowded mandibular symphyseal region, if you were to just go straight between the teeth, it is likely that you may make contact with one of the teeth roots. All you do then, seeing that crowded nature, just look at the angle between those teeth and change the angle and deliver. It is very, very straightforward. So the benefits of intraosseous anesthesia are that they're completely pain-free. You do not need a second injection. There is no numbness of the face. Bilateral mandibular treatments can be achieved in the same appointment, and fewer appointments made at the dentist because of that. Patients will no longer fear the dentist. They are happy little bunnies like a young Jeremy Viet there in the picture. So how can we be pain-free? Unlike a standard needle, which has 3 bevels, it has a main bevel and 2 little side bevels which render a point. That explains the little sharp prick that a needle may make, where it slightly tears the tissue. The Effitech needle from Dental High Tech has just 2. It has a main bevel and then on the reverse side a little back cut. What it does, it effectively creates a little scalpel blade, and the technique is just to push it down toward the tissue and start to deliver, not even pushing the needle into the tissue. So that little scalpel blade will just render itself submucosal with just the lightest of pressure. You'll notice where the lumen is of that needle. Because it's a nice flat bevel, it only takes a tiny entry under the mucosa to deliver that lumen submucosal. That's why you don't need the depth. This is a little graph showing what I may have done in the past with my manual syringe. Delivering a little bit too fast and causing some discomfort for the patient because it's slightly tearing the tissues. But with the electronic delivery, with the green line there, you can see it starts really slow, anesthetizing that first part of the tissue before it delivers the rest. Very controlled, very steady, no effort, no manual pressure, and a very happy and pain-free patient. The support points, you can see, I said, 1.5 miles away from the patient with a pen-like device which you can hold right up next to the patient. You have all of your other fingers, like you have with a pen, to support that device. You can get a bimanual, what we call circle of safety, around your patient. So much more controllable. So the summary of the planning considerations are as such. First of all, you have your proximity to the tooth. Ideally, you would deliver the anesthetic right next to the tooth that you're going to be treating. Now, sometimes you can't do that. If you can get right next to the tooth, you may only need a caution cartridge, and you can perform a half an hour of clean treatment, pain-free treatment. But sometimes you can't get right to the tooth because of proximity of the roots or indeed local pathology. In which case, all you do, the further you are away, you just deliver more. You will never need to deliver more than a single cartridge. Then you have control over the length of your appointment. For a simple, straightforward treatment, you may use a solution containing a 1 in 200,000 epinephrine. That's going to give you about 30 to 45 minutes of complete serenity. Or if you have a longer appointment, you may choose a 1 in 100,000 solution of epi, which will give you up to an hour and a quarter. So there we go. 4% articaine is the standard protocol solution. It is less toxic than lidocaine, weight for weight, and it is a much smaller molecule. So it actually passes through bone more readily. And then the 1 in 100,000, still with the 4% articaine. Now, you can get stronger epi concentrations with 2% lidocaine solutions in the US, and that is perfectly good, but you will get most of your treatment done with these two solutions. A video showing a clinical approach here, exactly the same as that animation a bit earlier. You get that stage 1 of the blanching. Once that blanching is residual, the periosteum beneath it is anesthetized. Then you can reorientate the same needle, make positive contact with bone, total pain-free, and I've had many of these done myself, so I know exactly how this feels. And then there is a little pause, and then the needle will rotate intermittently, 1 second rotation, followed by a little pause of 1.5 seconds off, and it will continue to do that until you have delivered that needle gently down to the appropriate depth, which will all be shown in the training associated with this. Once you're at that depth, you then just deliver the solution. It's all the work will be done with the foot pedal. There's no clinical controls on the device. You can see that the doctor's fingers and hands here are just purely supporting the device relative to the patient. At that point, you can start treatment immediately. So for the patient, there's no pain, no collateral numbness, happy, calm patients who no longer fear the dentist. For the dentist, you probably won't be surprised, there are more advantages. Immediate action is a reality and an incredibly refreshing one. There is no time delay between anesthetic delivery and active treatment. It's a massive time saving. There is far less stress. One of the side effects I found was that my stress levels just disappeared because I knew I wasn't going to cause my patient any pain. And that's a big advantage. No post-operative side effects. Appointment optimization, because you can now do multiple sextants in the same appointment, and an increased practice image. This is another thing which is a hidden advantage. Your reputation is hugely enhanced by this, and patients will go and tell others. And so with that in mind, I'll just briefly show you Christine. Christine was a patient of mine when she was a teenager. She was sitting here in 2014 here in this chair. She just had a mandibular treatment, a class 2 restoration on a mandibular first molar, and she sat up afterwards and she just made this little noise, and I said, "Are you okay, Christine?" And she said, yeah, I just I don't feel you've done anything. That's quite extraordinary. And I said, whoa, if I hold this phone, will you actually tell me about it? And she said, yeah, that's a good thing. So I want you to watch her face.
And it just feels fantastic. I can't tell any difference. It feels just the same as when I came in. I didn't know at all. It's so much better. It's fantastic.
Thank you, Christine. Thank you, Christine. Christine is absolutely chuffed to pieces that she comes around the world with me. Everywhere I go, she goes. She's very happy about that. So this is something that you can use in marketing. This is something that is very powerful. I've used this on Christine on my website as well as social media and all sorts of things. It's a powerful tool these days. So in conclusion, we now have an evolution of dental anesthesia, which has not been achieved since the 19th century. The future's here now, and it has huge advantages. Adopt this technology and you will have a remarkable benefit that you will perceive to your patients, to your team, yourself, and very much your dental business. So that's a little whistle-stop tour through the concept of the QuickSleeper in its electronic delivery and its intraosseous delivery. And I will hand you back now to the lovely Justine, who will start looking at questions.
Thank you, Andrew, so much for your presentation. I think it was clear and concise. That's perfect.
Thank you.
So now I will ask a question to the dentists who join us tonight. So some are using QuickSleeper since a long time, so are using QuickSleeper since few months. So it would be interesting to see the difference and what you think about it since few months or a few years. And Andrew will be here to answer deeply in other questions if we need. So I will start with Prabdeep. I would like to know, before using the QuickSleeper, what was your biggest frustration around dental anesthesia?
So my biggest frustration with dental anesthesia was the number of carpules to be used. So if I'm doing a procedure and I have to extract teeth, maybe mandibular teeth, so I would look at my watch that, okay, I have this much time, I need a block, I need to give infiltrations, and then I gotta make sure that the patient does not, become out of anesthesia in this time. So I see a lot of geriatric patients too. So the number of anesthetic carpules I'm using and also the time, it was also restrict what I can do that day, since I would refrain from giving bilateral anesthesia, especially in the mandible. So that was a bigger issue. Also with my kiddos, all the kid patients I see, of course, like anyone, like any other kid, they would be afraid of needles. So with QuickSleeper now, things have changed.
Okay, thank you so much.
Yes.
Andrew, you would like to add something?
No, that was beautifully put. I think the advantage. The question was about frustrations with traditional techniques, and I think I share many of Prabdeep's frustrations. I think the best phrase to use is, you don't know what you don't know. Before I started using QuickSleeper, I didn't know that I had problems. It's only once I started using it that I suddenly realized what life was like without them. It was a biggie. But thank you, Prabdeep. That's excellent.
Thank you, Prabdeep.
Most welcome, and you taught us well.
Thank you.
Richard, to follow up what Prabdeep just say, I know that you are practicing on a child pediatric, and I know that needle can be really scary. So did you feel a difference now on child by using QuickSleeper about anxiety, or child could have been scared before about them being shot?
Yes, the QuickSleeper is really amazing with especially with pediatric patients. So first thing, they do not feel, we're not having to fill their mouth full of topical anesthetic. When you put topical anesthetic in a child's mouth, I mean, your appointment just goes downhill from there because they hate the taste. So that is not necessary. Topical anesthetic is not necessary on a child or adult. So using that special Epitech needle, you're able to gain anesthesia in the gum tissue where you're going to be drilling down in with the Epitech needle. They do not feel that at all. It's amazing how they just are, they just don't feel it at all. And then with children, because the development of their bone, the cortical plate, is almost non-existent or very, very thin. So all you're doing, they don't even feel the vibration. You don't need to use the motor to go down into their bone. Basically what you're doing is just pushing it into their bone. And this can occur all the way up to around 12, and then you have to maybe start using the motor. But I mean, this is a situation where they don't feel any anesthetic, they don't feel any taste, and then they do not feel you pushing into the bone, and you gain instant anesthesia. So you have this situation where your time has been completely cut down, and then the after effects are amazing. They're not biting their lip, they're not chewing on their tongue. You don't have to give this big discussion to the parents of, hey, don't let your child scratch their face. And so it's just an amazing device for children. I just absolutely love it. The children that I've used this on has been 100% great experience, and it's just amazing. Just really, really wonderful. Total game changer for my practice.
Richard, do you have in mind a precise case, a story on child that you would like to share, something just you kept in mind because you use it now since a long time?
So you want a particular experience on a child?
Yeah.
Yeah, so just this last week, I had a child come in. They sat down in the chair. I had two mandibular fillings that need to be done, and a space maintainer removal. And so I just gave a little anesthetic in between their permanent tooth and the two mandibular or the deciduous molars. And they felt nothing during the delivery of the Epitech needle, getting the gum tissue numb. So they felt nothing. There was no topical anesthetic that they had to feel or taste or anything like that. And then I just pushed it right in between in the papilla area, right into their bone. And it took about a half a carpule to be able to get all the teeth in that quadrant numb, including the molar, the permanent molar right behind. So I was able to deliver, get two fillings done and remove a space maintainer without the child feeling anything. And this took all of, including the anesthesia, probably about 20 minutes.
Impressive.
It was awesome.
Yeah.
Story.
Yeah, very, very impressive. I know Justine will hate me, but I'll add something to that when it comes to the time. I was standing over a doctor treating a young lady, and she'd planned 2 quadrants in one appointment, and that was very doable. So she did the first stage, and then the second stage, and then she was waiting while the third stage delivered, very gently delivered the anesthetic. And she was immediately getting very frustrated. The doctor, she was saying, "Oh, is it done now? Can we stop? Is this enough?" And I was saying, just have patience, just let it happen. It will be much, much quicker than your traditional, but it just takes a nice time because it's being very gentle for your patient. Anyway, to cut a long story short, she finished that, got on with the treatment. I, like a good boy, had changed the needle over and handed the device back to her when she had finished the first quadrant. She did exactly the same with the second quadrant, got all frustrated with the length of time, finished that, and then she did this extremely comedic double take at the clock. She looked up and she glanced up and she went and looked, and she couldn't believe how quickly she had just achieved those 2 quadrants. So, as I say, to cut a long story short, she ended up doing 3 quadrants in the same visit that she had planned 2, and had got frustrated over the speed of delivery. So much faster. Brilliant. Thank you, Richard.
You're welcome.
Thank you, Andrew. So question for Ramin. So you use the QuickSleeper since few months. Could you share with us your first injection, the first injection you gave with, and share with us if it was easy to learn, to take in hand, if it took time, first injection?
The first injection was my assistant, and we did this with the aid of Dr. Prynne on FaceTime, watching me deliver the anesthetic. And the reaction was exactly what has been promised. I mean, you will get, which was nothing. Like, wow, this was unbelievable, and I'm pretty numb. And we gave it right in the most challenging, I would say, area you want to numb, that has the most nerve endings between central incisors. Just, it's never a comfortable area to anesthetize for a patient. So, and he was numb from almost, I think I gave a half a carpule, and it was from 6 to 11, a canine to canine, maybe even a little bit further. That was pretty numb. And and I also have to say for my practice, I know you guys doing restorative, what has been really an absolute game changer is if you're a cosmetic dentist and you're delivering veneers, you're going to get that droopy smile and the lips coming down, and you try to ask the patient to see their veneers. Do you like it? And they're like looking at this sideways, and there's no collateral anesthesia of the lips, and that's been unbelievable. Like, they can function and they can talk. They don't have droopy lips afterwards or during the process. They're just numb on the teeth where you want them to be numb. That's clearly remarkable. And I think, I don't know, you what was your first?
No, I can't remember which one was my first, but yesterday we don't usually treat children, but I did treat a 15-year-old yesterday, and she's had, unfortunately, a history of a lot of cavities, and she's new to our practice, and so I went to numb her to do a restoration on 29 and 30 in the lower right, in the premolar and the molar, and so she's like, "Oh, I usually get gas when I get an injection." I said, you're really not going to need this, and we have a nice rapport. So she really trusted me, which was great. And I said, first, I'm going to numb the area so that when I do give you the anesthesia, you're already numbed. And she says, okay. And when I did the first, the infiltration, the first phase, and she didn't know I did it, it just set the whole tone for the rest of it. So then when I'm telling you, you're going to feel a little buzz, whatever, she was already sort of relaxed and trusting. And so when that did come, she got a little startled by it, but then it stopped as soon as I went a little deeper. And she's 15 years old. She's like, I didn't even pull the thing out. She was already numb. And she's like, I'm feeling it, have it in her mouth because it's giving it nice and slow. And she's like, I'm feeling numb already, and I didn't really tell her it was anything special. I didn't want to, lead the witness. But this was her reaction, So it was great.
Your approach is very wise. Very good.
Thank you, Elisa. Prabdeep, I know you sent us already some testimonial of your patient. I saw that they were really happy that you used the QuickSleeper, and you changed from a manual syringe to the QuickSleeper. So it's a big gap. How you feel your patient now, the reaction regarding the painless experience and the face numbness that they don't have now?
Since I'm using it for 8 months, so it's actually hilarious because I had some turnover with my assistants. So not all, I'm still training few of them. So they don't know that I'm using QuickSleeper on almost each patient. So they'll put in a manual syringe somehow, and then whatever is loaded. So I go ahead, and then get started with it, and then ask me, hey doctor, aren't you using the other thing you used on me last time? I was like, oh, really? I use the QuickSleeper because it's a recall, right? I see them every 6 months. So I don't know which patients I already treated with QuickSleeper and which ones, are getting. So I was like, okay. Then I called my other lead assistant and said, okay, let's get started with QuickSleeper, because now they're demanding it, use that thing, use that device. So they're really happy. And as I said, being in a small town, this is new technology, not even for them, even for practitioners like me. But they spread the word across, and they're not afraid anymore. That's the biggest thing. Be it adults, be it geriatric patients, be it kiddos. And in fact, my team members are more confident. Before I even go in there, they'll say, oh, it's not going to hurt, you're just going to feel a little bit, and that's all. So even before I go in there, the parents are at ease, the patients are at ease. And of course, as clinicians, it does make a lot of difference. Yeah, they're very happy. They're very happy. They're asking for it specifically. Use that device, doctor. which you used Almina.
So this is a really effective example of it being a practice builder, isn't it? And also that shows how much they actually love it, because it makes such a difference from traditional techniques. Thank you very much. That's brilliant.
Absolutely.
Thank you very much. I will ask a question for Richard. All the time we have questions about the price of the device and the ROI. I know that you invested a lot in your practice in different technology. How you place QuickSleeper regarding the efficiency and the ROI in your practice?
Yes, the QuickSleeper is one of just many devices, tech devices that I have in my office. I have a 3D printer. I have a full CEREC system. I have the ovens. I do same-day dentistry, and I have artificial intelligence with diagnosing radiographs. We have a cone beam radiograph. But I have to say, I've spent over $300,000-$400,000 on all of these tech devices, and there is nothing I can honestly say that has made more of a difference to me monetarily and stress level than this device. It was worth every penny that I have. Every time I use it, I go, this is the best thing I've invested in years and years and years. First, it takes the time. The real benefit is your time, right? Time is money, as they say. And if you're an insurance-based office, which I am not, but if you're an insurance-based office, when you get behind on your schedule, everything goes out the window, right? And so the things that I'm able to do now, I can do 3 quadrants of dentistry in the same amount of time that I did one. And if there's a failed anesthesia, it wipes your schedule out and you lose all of that production. And so this is such a game changer for my return on investment. It's the best thing that I've ever invested in a long, long time. So I'm just really grateful to Dental High Tech that they have this in the United States now and that we can use this. It's a game changer for your office, truly, financially.
Can I just add something? I think I like what he's saying. After a patient trusts you as their dentist, there's 2 reasons why they would not go through with treatment: cost of treatment and pain that you may cause for them. So if you can get past the cost and they're coming to you, there's still that fear of dentistry and fear of pain of anesthesia. So why would you not want to learn a system that is really painless? To me, it's like, I would want to invest time, money, effort to learn this system to deliver the least or completely painless anesthesia possible. I mean, that's why.
Well, that's why we used the wand for so many years.
Right.
When we did that,
And this far so that.
we had our patients asking our specialists, like say they went for a root canal, why don't they have that as well? And now how we see this is that this is taking the wand and we've moved now into even more modern and more effective and less painful. So it'll be interesting how that plays out,
Yeah, it's good. The only thing above this now is for us all to become Jedis, and then we go, you will feel no pain.
Thank you for sharing that. Elisa, as you said about the painless experience and everything, and I know that there is a lot of dentists, when you use the same method for a long time, it could be hard to change and learn something new. I know that you, Elisa and Ramin, you use the QuickSleeper since a few months. And Ramin, you learn in fast time with Andrew, but after you attempt one of our hands-on. So for you, is it long and hard to learn, or no? If you should answer to people who are asking, I don't want to learn something new because it will take time and everything.
I think every time that I've been using it, it's sort of exponential. There was a little anxiety when you're first doing the first couple. the anxiety has really dropped now. It's more about like, okay, do I have the right angle? Am I doing this? You know, and each time I learn something and I do it a little bit like more correct, say, you know, and I feel more confident. But it's just sort of jumped. It's been very fast, actually.
Just imagine picking up the handpiece for the first time and trying to drill a tooth. How nervous were you doing that? You know, it's the same thing. You're picking up a new technique. It's going to be a little bit of trepidation and anxiety around it because of you learning a new system that you need to know the techniques well. But once you get over that hurdle, like anything else you do in dentistry, it becomes second nature. You know, like if you gave me a manual anesthetic, I don't even know how to inject it with a syringe because we haven't used it. We've been pressing on a foot pedal to deliver anesthesia. For us, the transition was very, very easy. So, yeah, I mean,
I totally agree with that.
So critical to learn this.
Yeah, I mean, what you say rings very true. If you can imagine now, not having given a block in over 12, 13 years, you're right. I wouldn't have a clue. I would be frantic. I'd be as nervous doing it now as I would have been that first time I did it at Stab Lab in the hospital. But genuinely. Great. Thank you.
Thank you, Andrew. Richard, I know that now you don't like block anymore. I know that when you are without your device, you are not really happy. So for you, why and what's the main benefit of Intraosseous compared to block what you used to do before?
Sure. The main benefit to me, our profession is really stressful. And when you're dealing with managing a patient that has all kinds of issues, both psychologically and everything else, it puts a stress level on you that can just completely wipe you out by the end of the day. So the main benefit to this of this device for me is the stress level has just gone down so much for me. When I walk in the room, I know that I can deliver painless, quick, and profound anesthesia. At my office, we have a 24/7 emergency service, and so we see these patients that are in massive pain, that have large abscesses or hot teeth that are just really difficult traditionally to get numb, especially on the mandible. I've had problems on the top too, on the maxilla. But I know when I walk in the room that this patient that's in severe pain, I can gain immediate and profound anesthesia, even in those difficult situations. And that takes my stress level down. And that's why I love the QuickSleeper so much. It just makes such a difference in my overall attitude towards the profession and helping my patients. And many people have mentioned today the huge benefit it is to other patients that are hearing about your office being this painless place that you can get treatment done without having pain. It's an amazing thing, really.
Thank you. I want just to add something. I have a lot of people are just asking what's the real difference for intraosseous anesthesia than block. And when you master block, you have no problem. So what you can answer to those dentists?
Yeah, so I have found that probably 2 out of 10 mandibular blocks for me are either incomplete or complete fails, and that's a statistic that I think that most dentists that I've asked find that to be the same. And so you're either trying a different anesthetic, different approach, you're delivering as Prabdeep said, she's having to deliver many carpules of anesthetic to be able to find the place. And so this is a slam dunk way of being able to deliver anesthesia with sometimes less than a full carpule. And it really is a really great, how do you say it? Almost completely dependable way of delivering anesthesia, where I could never gain that absolute situation with every single case, especially on an inferior alveolar nerve block. It just wouldn't happen for me 100% of the time. And I can continuously and absolutely say, hey, this is going to work for me on this patient.
Picking up on your stats there, you said 1 to 2 patients in 10. That actually sounds anecdotal, but you lie absolutely smack in the middle of all of the studies and the papers. The papers, a review of the papers going back many, many years has shown that it is a consistent 15 to 20% of inferior alveolar nerve blocks that are either fails or suboptimal. So you're absolutely there in your experience with all of the studies over many, many years.
Mm-hmm.
Thank you, Andrew. Thank you, Richard.
Mm-hmm.
Prabdip, I would like to know, before you never used intraosseous anesthesia, you were using a manual syringe. So which vision you had before of intraosseous anesthesia, and what is your vision now that you are using it every day?
I just lost you in between. Could you repeat it? I heard that part where
Yeah.
you said that I hadn't used intraosseous anesthesia and then I was using traditional. Second part of the question?
Yeah, so what before you were thinking about intraosseous anesthesia because it was new for you, and what now you are thinking about that after using it every day?
Right. So this is something I read in school when I was doing my DDS, that, okay, we have some wand system, and I was always interested to learn about it. But of course, wherever I practice, we didn't have, there were no such devices that I could use. But then once I came across this, one of the practitioner was using it around my area. And I was blown by this. I actually saw her doing this, and that was the previous version of QuickSleeper 5. I'm talking about the just the pediatric version. Once I saw it for myself, I couldn't believe my eyes. That's when I called you guys. I was like, I have to see what is this device, which actually, you need not wait for the anesthesia to kick in. The kids don't feel the pressure of extracting a tooth, and then it was actually very seamless, the whole procedure. Now I think that it should be readily available to everybody, and it is right now. As one of the doctors just mentioned that, yes, it's been in US and it's very much available. Now we just have to do is spread the word, because 30% of the people in our practice, I would say, and for that matter, anybody, anywhere you go in the States or worldwide, the number one reason they don't want to go to the dentist is the fear of the needle. I've seen, and after introducing this, I've seen spouses brought their, their husbands, or maybe any family member, their kids, or vice versa. Daughters got their moms. Okay, it's not going to hurt that much. There's a different device they're using. They're using QuickSleeper. So that itself has, increased the acceptance, not just to treatment, but also, they've broken that barrier that, okay, pain should not be the limiting factor for dental care. So not just a game changer for me, but it helps me talk to the patient and, channelize their fear into, acceptance that, okay, we'll go past this step. That's huge for me. Thank you.
Thank you, Prabdip.
Thank you.
So as I said before, most of the dentists have the fear to change the actual method. So Ramin, because you use QuickSleeper since less time than the other dentists here, so which advice you can give to a dentist hesitating to change learn and change the organization in the practice around the anesthesia delivery?
Have yourself anesthetized once. I think once you realize how painless it is, you're sold. I mean, just get anesthetized. Find someone who has it. Say, can you anesthetize me? I like to feel it. I mean, you want to really know it works. Get yourself anesthetized by someone who in your area or somewhere. I would want to know if it really works. That to me is an absolute. When I first got numb, like, wow, this is pretty remarkable. So,
yeah. One of the things that I think Justine was also asking there was about what changes you've made in the office. Now, if I was going to be brutally honest, for those listening to us today and on the catch up on the website, one of the things that I always advise is get to know the device, get to know how it works in your hands, get to know when to use it, where to use it, perfect the art, and then sit down and calculate how much time this is saving you, how much you can shrink your appointments, which is real. You can actually shrink your appointments. Half-an-hour appointments would go to 20 minutes. Now, at my age, in 2014, I could shrink all my appointments, and then where my younger colleagues would add patients on at the end of the day, I would perhaps shrink all my appointments and then go home. So either way, it takes a bit of organization, a change in workflow in the office, a change of your appointments. And I think that's what you were getting at a bit there, Justine. You can change your appointment book to make your day hugely efficient or just that much more pleasant. But don't, I always say to people, don't rush into that until you have really assessed how this works in your hands. But it will save you time. You've just got to work out what's the best.
May I jump in and add something there? So one thing that I think the learning curve for this is very, very short. I mean, I'm constantly learning all the time how to make it more effective, especially in difficult situations. But really the learning curve, you know, and the fear is just really just not there after a couple of days. It becomes almost like riding a bike, and it has some little technique things that you need to learn, but it is really not that hard to learn. I jumped right in, and it's been you know, the first 30 days was a learning curve. There's all these neat little things that I learned, how to become more effective, how to work with children, how to work on difficult, you know, inflamed teeth, and how to do all those things. But really it's not that difficult. It's, and especially with the training that Dr. Prynne gives you, or one of the other trainers gives you, you're going to have a real great success right from the start, truly.
Thanks, Richard. That's great.
Yeah, I would like to piggyback on that. So it's not just a device that that high tech is promoting. It's also the value added to it by the mentors. You can reach to them if you need more hand holding, or you're just okay by yourself, just a question or two anytime. I mean, they're always there. They'll just not leave you.
Instead of FaceTime anesthesia.
Was that?
That's a perfect example.
Consider FaceTime anesthesia.
Never heard that before.
Yeah. That I can tell you, Ramin, was a lot more frightening for me than it was for either you or your associate.
Well, I wasn't frightened at all. I knew I was.
It was the first time I met you, wasn't it?
Guided by the right person.
So, Justine, what have we? We've got a number of questions from the delegates.
The chat. It's exactly what I was looking for. So we will answer to the question we have on the chat. If you have question at this moment, drop it in the Q&A, and we'll take time to answer with Andrew. So before I take all the questions, as all the dentists tonight said, it's better to try it. And it's like what everyone asks us, where can I try it? So we have two solutions for you. We organize monthly one event per state. So this is our upcoming event. We'll be in Texas in July and in New York in September. You can scan the QR code and you will see all the events for 2026. So even for after October, November, and December. So feel free to scan the QR code and you can register directly on hands-on course, study club, the event fit for you. And we have a second solution to try it, not on the event, but at your office. We propose loan program. Andrew, if you can change the slide, then they will see what is it. Thank you. So this is our loan program. It's 30 days where you can try the QuickSleeper at your office and on real patient, real condition. We are here to onboard you and follow you all the months. We have a weekly call with you, the Dental High Tech team and Andrew, who is helping us a lot for this program. Then you are able to ask all your clinical questions and we help you to really learn about the device and use it well. And at the end of this month, you choose if you want to keep it or if you want to return it if it was not the good fit for you. So it's 30 days to try it before engage yourself on the device. So now we will take the question in the Q&A and we will answer to each question with Andrew. I don't know, Andrew, if you see the Q&A or you want me to read you the question?
We can do both. Let's have a little look-see.
Yeah, so I have the first one. What about the ridges buccal lingual?
Thin ridges, buccal lingual. Just to understand that, are you talking about the thickness of the bone or where the bone has reduced vertically? I will try and answer both. If the ridges are very thin, and I would like to give an example of the difference between the posterior maxillary or mandibular and the anterior. In the anterior, as you say, and I think buccolingual thinness, you're talking about the fact that the cortical plates in the mandibular symphyseal region are very thin. All you need to do is assess that physically, and then just as one would if you were placing an implant or doing anything that involves a three-dimensional assessment of a situation, you would just make the device a little steeper. So you would reduce the angle between the device and the long axis of the tooth. That's what you would do. It's simply a matter, all you're looking to do is to deliver the needle into a good volume of bone. Ideally, it will be midway between the buccal and lingual plates and midway between the adjacent teeth.
Thank you, Andrew. Second question, will the needle do damage if it touches a root?
Go on, Richard, take this one.
Sure. Yeah, so I have hit a root before, and it will not penetrate into a root. It's been shown through multiple different studies that this needle will not drill into a root. It can penetrate down into the periodontal ligament space, and you will be taught in the class what that feels like or what it sounds like and how to deal with that situation. But to answer your question, it will not damage a root.
This is absolutely, I completely agree. It does not have the strength to do that. And one of the wonderful things about this device is that there are lots of safety features built into it, both the electronic sensors within the plunger, the electronic sensors in the rotation of the motor, and it will not, fundamentally, it will not let you do any harm to your patient. So long as you follow the protocols, it will not allow you to do any harm to your patient. Thank you, Richard. Great answer.
Thank you, Andrew and Richard. Other question, which size needle do you recommend for different situations?
Well, I hope this will be visible. There are 3 needles in the Effitech range. The standard protocol needle is your white needle, which is 16 millimeters long and 30 gauge, a very narrow 30 gauge. If you have got, I use that for pretty much everything, except if I have assessed on the radiograph that the cortical plate is thick or that the bone is very dense, or if I am by protocol doing a transcortical injection. That means where there is no septum. So an edentulous area, retromolar trigonum right at the back, out here in the jaw, any area like that, I will use a yellow needle. That is a 16 millimeter 27 gauge needle, just a little more robust. Otherwise, it's exactly the same. For the, as Prabdeep has said, for the kiddos, and for perhaps a PDL, an intraligamentary injection, or perhaps just a palatal injection, if that's what you want to do, because accessing from the palate is also possible, then a green needle could be used, which is a 9 millimeter ultra short 30 gauge needle. So very, very fine. And those are the sort of, you won't need any more than those 3. Those will cover the whole mouth, no problem at all. I would say 90% of my time I'm using the white. The other 10 I'm using that. In adults and in children, almost 100% I'm using that. That's my answer.
Perfect.
And I'm sticking to
Yeah,
it.
perfect, Andrew. I think that's clear. Another question, is the QuickSleeper good for implant, and can I use it on all cases?
Who places implants here? Okay. Yep, Richard.
Yes. Yeah. So I think this is one of the best devices ever for implant placement. First, you have to know that it will get all of the anything that periosteum covers, it will get numb. It will not get anything outside of the mucogingival junction numb. So if you're doing a complete flap, then you may have to give additional anesthesia down in the unattached gingiva. But when you're doing like anything where there's periosteum, it gives instant anesthesia and complete anesthesia. Another benefit too is when you have the cancellous bone with a vasoconstrictor in there, the bleeding is also significantly less. So an immediate placement, my time on an implant has been dropped down by 20 minutes about when I'm placing an implant. So it works very well for implant placement, and you can do multiple implants placed in the entire quadrant. Now, if you're doing like an all-on-4 or something like that, where you're getting all of the things, everything needs to be numb, including all of the unattached gingiva, then you may need some supplemental anesthesia. But if you're just doing osseous ridge placement right through the attached gingiva, it is magical, truly.
Yeah, completely agree. I would perhaps be less generous with the full arch cases. With the full arch cases, which are primarily soft tissue anesthesia, then I only have one syringe, or I only had one syringe, manual syringe, in my office, and that was double bagged at the bottom of my implant kit and only used for those full arch cases where I'm spending the whole morning doing big flaps, bone remodeling, implant placement, GBR, everything. The anesthetic needed to be in the soft tissue for that, and the QuickSleeper would have done it perfectly, but it would have taken unnecessary. You don't need the delicacy in those situations, if I was going to be brutally honest, and that's when I would just be filling up the soft tissue where necessary with anesthetic, with a manual syringe.
So single implant placement, it's perfect.
100%. QuickSleeper, perfect. And as you
And
said, multiple in one quadrant. You know, that's perfectly possible.
thank you for your answer, guys. Next question. Good question. What if the needle enters the mandibular canals?
Shall I take this just briefly? With bone height being in the normal range, the 16mm needle delivered 12mm into the tissue would never reach it. However, you are quite correct in saying that there is a potential for you to enter the mandibular canal. Will the patient let you? Absolutely not. One of the reasons why, if we're going back to implants, that implant surgeons like to give a very light anesthesia in the posterior mandible is so that even with all of the CT planning, if there is any possibility that that drill is going to go near the canal, you want the patient to be able to tell you. So if you have assessed on a radiograph that there is a vertical bone loss in posterior mandible, then there is no more septum. And by definition, you then go to a transcortical technique, which means that you're just going to drop just through the cortical plate and stop, because that needle is already then in a good volume of bone. So yes, you need to be aware of the mandibular canal, the alveolar canal. Have I ever gone anywhere near one? Absolutely not, simply because I've followed protocol, and where there is no septum, I've just delivered that needle just through the cortical plate. I think, quoting a wonderful lady called Laurie Johnson, who is a pediatric doctor, when asked, can you hit a unerupted tooth germ? She said, yes, you can also put it in someone's eye, but you're not going to, are you? Mm-hmm. And that was her answer, and I thought it was absolute genius. Anyway, protocol will keep you well safe.
Thank you, Andrew. Next
Has Justine
question.
frozen?
Mm-hmm. Any info on adverse events? Any history of bone necrosis?
I think everyone's frozen.
Hear me, Andrew?
I think Andrew's gone.
It's just Andrew. I will keep this question. Richard, you want to answer to that?
Sure. So are we talking about bone necrosis? Yes. So there is a chance of bone necrosis. However, if you're using the appropriate protocols for injecting down in the bone, what you're looking for is a good volume of bone in the area that you're injecting into. And so if you have a small, narrow portion of bone, then and you inject too much anesthetic down in there with a lot of vasoconstrictor, it can cause necrosis. But this is very, very rare. This is a thinking dentist's device. So you are evaluating, and you will be taught how to evaluate the volume of bone that you're injecting into. When you understand that and you follow the protocol, you're not going to be injecting a lot of vasoconstrictor into an area that it has very little volume. And that is one of the key protocols that we have to follow when we're using this device. So if you inject a lot of anesthetic with a lot of vasoconstrictor in a very small volume of bone, you can cause necrosis. So to answer your question, yes, but once again, just like the inferior alveolar nerve canal, you are not going to inject down in the canal, because you're going to follow the protocols and understand the limits of this device, and understand, looking at the anesthetic. So you are the bone view from either a periapical or a CVCT. So it's a thinking person's device. So you're not going to have that situation if you follow the protocols that you're taught.
Very sorry, I think I may have disappeared then.
You disappeared.
Thank you, Richard, for taking over.
Thank you, Richard.
Yes.
So where we are in the question about the onboarding process. What is the onboarding process like? I will answer to that. So the onboarding, you have a full e-learning platform with different video to help you understand the concept and give you a good base. And after, so if you are with the long program, you will have an onboarding call where we'll help you to set up the device. So it's really focused on the use of the device. And after, we have a weekly call with you to discuss about your first case, about your experience, and help you managing some difficulties if you have, and use better the device until you are completely good and you feel comfortable with. The onboarding process is, I would say, it's a short process, but the learning curve it's infinite, if I can say that, Andrew. You will see that you can have questions even after a few months of use. Depend what you were using before, if you were comfortable with intraosseous anesthesia or no. You can take more or less time, depend your experience.
Yep, lots of support there. Adverse events, Justine. Any history of bone necrosis? I would be lying to you if I said that that has not happened. In each case that I have seen where it has happened, which is mercifully very rare, there has been a serious diversion from the protocol. For example, bone necrosis is in theory quite easy to achieve if you deliver a large volume of anesthetic solution containing a high concentration of vasoconstrictor into the crestal area of a septum where there is minimal volume, because what you'll just achieve will be a very strong chemical vasoconstriction and in addition a mechanical vasoconstriction due to the pressure. Now what this will create is a prolonged ischemia which could then lead to necrosis, and so it is indeed possible, but the protocol is very straightforward to follow, and you just stick with the protocol like you do with any other discipline in dentistry and you won't go wrong. But I would be lying if I said there weren't any adverse events of necrosis. It's possible, but you will avoid it.
Link with that, and can you use carbocaine and bypass the epi vasoconstriction?
Yes, you can use it, and I would always suggest that that would be for smash and grab treatments. It would last no more than 5 to 10 minutes because of the very vigorous blood supply within the cancellous bone. The anesthetic solution would be washed away very, very quickly. It's a highly vascular bone.
Thank you, Andrew. What if there is no space where I want to inject anesthesia? Can I go palatal at the top?
Yes. Remember the one thing I said a bit earlier. All you are looking to do is to gain access to that bone, that box, that chamber. How you get there is very much up to the clinical situation that you see in front of you. So there is palatal access, there's all sorts of access. The standard accesses will be the osteocentral and transcortical that you will be taught and you'll see in all of the lectures.
May I add to that a little bit? So, so as Dr. Andrew taught you in his presentation, the anesthesia will certainly go one tooth on either side of where you're injecting. So especially on the upper, you have that multi-directional blood flow, and it flows really well, 1 to 2 teeth at for sure on either side of the place you're injecting. Now on the bottom, that's a little different. You're depending on the unidirectional blood flow from distal to mesial. So you are injecting, but you'll gain profound anesthesia on one tooth on either side of where you're injecting. So to answer that question, you just go to a nearby spot, yes, and know that you're going to have to go best if you could go distal to the area of you're working on the mandible, and then not so much concerned about that on the top because it just distributes evenly across the jaw, including on the palate as well, by the way.
Very true. Just another access. It's good.
Thank you. I think we'll take one last question because we are already at 1 hour and a half from the time. So how much of the carpule are you giving? What anesthetic do you use? And the epi content?
You'll never, I've made the statement, you'll never give more than one cartridge. Just before I throw this question at the Manhattan team, that's all you're ever going to use. From a cost point of view, we're talking about $1. 30 cents, the balance. That's the cost of each job. Unlike some devices which you need to replace the needle, the holder, the tube, and the cartridge holder, it's a huge cost saving from that. What was I going to throw at the Manhattan team?
Not sure.
How much? Oh yeah. So
Maybe one.
you'll never need more than a full cartridge. What would you normally use in an average job?
I've been using 3/4 has been my go-to, and I've been using one whole carpule, like when I'm delivering like a bunch of veneers.
Mm-hmm.
I want them, but yeah, I mean, never had to redeliver, go back in and add another.
I haven't had to
another
top,
top it off or not. You know, it's been.
I use
The only
half
times-
too. A lot of times, if it's a smaller filling and I know it's going to be fast,
Yeah.
and you know.
I saw a question
absolutely.
about carbocaine. Yeah, I know you definitely don't recommend using carbocaine because you need the vasoconstriction. If you have no vasoconstriction, there is no anesthesia. So carbocaine is not a good choice.
Yeah, it's gone. But as Elisa said, sometimes when you're very close to a tooth that you're treating and you're doing a quick treatment, I've delivered just 1/4 of a cartridge in the past, but from a cost point of view, of course, that cartridge is then gone. That's used. So the cost is that. But with regard not going in again to top up, I've topped up on a regular, frequent basis, not because my anesthesia has failed, but I need a longer appointment. So if I'm doing my CAD/CAM work, like Richard was talking about his CEREC unit, I had a CEREC unit, and I would regularly go an hour and a half plus. What I would do is I would always, after I delivered the first primary anesthesia, I would always say to the patient, oh, by the way, you know this is a long appointment. Yes, I'd say, well, in about an hour, I'll be topping that up. Is that okay? And they just, it was almost like, why are you asking me? I didn't feel the first one. So I would go in routinely at an hour, and I would just get into the same protocol positions, and more often than not, drop straight back into the same osteotomy that I did my primary anesthesia with. So that's the only time I would give more than one, and that is if I was going on a long visit. There is one little question I see there, Justine, about the power supply. It's just
the one I would like to take before we leave. I think it's important to answer to that.
There you go. That's
and you have with you.
Normal little power brick, which powers the control box, which you never need to worry about where that is, because you never need to access it. That is the computer. That can be tucked again underneath your unit or on the back of your unit, as mine was. So the power supply can come in through the chair. Mine did. The only advice I'll give there is that if you have a new chair which is under warranty, don't go doing it yourself. Get your installation team to do it. My chair, my old Sirona chair, was way out of warranty. So I just took all the panels off, as I often did, to do various things, and I led a low voltage cable through from the power brick straight to the dentist unit. So my device was installed on the chair all the time, just like any other instrument, because I used it every single time. Every single time. I had no routine syringes in my office, so yep, it was all installed.
I would like to add about that. I know that there is some dentists are using the device in several rooms in the same office. So the control box is pretty small. Everything is pretty light. So it's really easy to move it every day if you want to use it in several rooms.
Yeah, I would like to add to it. So I have 3 operatories. That's how I operate, and that QuickSleeper is actually following me in each room. Jeremiah was there, and he actually installed one of all the holders in all of the rooms. So all I have to do is ask my assistant, and she just comes in and plugs it in. That's it. And the control panel, everything travels with it. So it's pretty easy, and it's not that heavy as well. So yeah,
it's very easy to transport, as Prabdeep says. However, that's if you're a single operator in those 3 rooms. If
right.
you are operating out of one room and you are using it, sharing it with 2 others, that will cause fights in the corridor between the assistants, who will be saying, no, I want it, no, I want it, no, I want it. It's a problem. So under those circumstances, you need one in every room, and that's what we did.
Right.
Great questions. There's one more, Justine, I'm really sorry, which I think is worth answering. There's a very good question here which talks about what if there is a large periapical radiolucency and there's no bone in the area. Will intraosseous anesthesia work? Yes, it will work. You do need to just go slightly further away, because one of the rules with intraosseous anesthesia, exactly as it is with traditional techniques, is you don't go injecting into an area of pathology or disseminated bacterial activity. So the answer is yes, go away from that. If there is a tooth, for example, with a kiddo, as I'm using all Prabdeep's terms now, with a kiddo, if the bone has gone from around the roots of a tooth which is becoming naturally avulsed, then don't expect that tissue to be anesthetized directly from the bone, because there's no contact with the bone. So you're right to say there's no bone in that area, there will not be anesthesia. However, with a lone pathology like a radiolucency, like a radiolucent area, he says, using a radiological term, just go somewhere nearby and that will flood that area and by diffusion. So yes, you've answered your own question accurately. Good.
Thank you, Andrew. You see other questions that you want to answer?
I
think even if there is other question, it was kind of similar from others, so I took the most relevant. And for the question we couldn't answer tonight, I will reach out by email to share more information if needed.
Perfect. Any questions that are asked on this venue which we haven't got to, we will answer it after this. But I think we've covered most of them, actually. Justine, you've done a great job.
I think. Thank you, Andrew. All right. Thank you, everyone, for tonight. If you have other questions, feel free to reach out by email. We would be happy to answer, or me or Dental High Tech team, or Andrew if it's more clinical question. And feel free to visit our event website if you want to try it in real life or apply for the loan program. You can apply directly online. And if you couldn't scan the QR code, you will receive an email after the webinar with the link to apply. I hope it helped tonight to better understand the QuickSleeper and intraosseous anesthesia. And thank you for your time. Thank you, Andrew. Thank you, Prablit. Thank you, Rami and Eliza. And thank you, Richard, for your time tonight. It was great to have you with us.